Hello, everyone, and thank you for joining us for a special installment of our Policy Lab webinar series. Policy Lab is a research center within Children's Hospital of Philadelphia's Research Institute, and during the month of May, which is Mental Health Month, we'll be focusing several 15-minute webinars on various topics under the umbrella of behavioral health. You can see a list of the topics we'll be covering on the current slide, as well as a link to the landing page where the webinars will be posted. We encourage you to visit our website, policylab.chop.edu, for more information and to share these webinars and other resources via Twitter, tagging us at @PolicyLabChop. Today we'll be focusing on the topic of behavioral health in schools with Dr. Jamie Young, a clinical psychologist at Children's Hospital of Philadelphia, and Dr. Jennifer Mautone, a school psychologist at Children's Hospital of Philadelphia. They are also both faculty members here at Policy Lab. I'm going to hand it over to Dr. Young to get us started.
Thank you. We're grateful for the opportunity to talk to you today about school-based mental health and some of the work we've been doing developing and studying school-based prevention and intervention programs. We're going to start today by giving a brief overview of why schools are an important setting for the delivery of behavioral health interventions, to anchor school-based services in the continuum of behavioral health care, and to outline the multi-tiered systems of support framework that is used in many schools. Then we'll go through 3 examples of our own school-based research. As many of you are probably aware, 20% of youth have a serious mental health condition, with a much larger percentage experiencing mental health symptoms that are causing some impairment. Most psychiatric conditions begin in childhood and adolescence, pointing to the pressing need to address mental health problems in youth. Despite this need, only about 20% of youth with a mental health problem receive specialty mental health treatment. Research shows that the majority of youth who receive mental health services receive these services in schools and other non-specialty mental health settings such as primary care. School-based programs address many of the barriers that youth and families face when seeking services and promote access to care for underserved populations. Additionally, from a prevention framework, schools provide a key setting to target problems before they reach diagnostic criteria. Despite the potential benefits of delivering mental health services in schools, research demonstrates that many school providers are not delivering evidence-based interventions. Much of the work we will discuss today is focused on bringing these evidence-based behavioral programs into schools. I'm going to turn it over briefly to my colleague, Dr. Mautone.
Thank you. So if we think about the continuum of behavioral health care, the programs we're talking about today are really at the base of the pyramid, as you can see here. As we just heard, by integrating services into settings where children and adolescents spend a lot of their time, like in schools, we can improve access, reduce stigma, and address difficulties early. We just saw that there are different levels of behavioral health care, and school-based programs typically fall within the lowest of those levels. Then within school services, we often think about multi-tiered systems of support as illustrated here. Programs can be school-wide or universal, where all students in the building have access to the strategies. For example, school-wide positive behavior support programs are often used to teach behavioral expectations, recognize and encourage appropriate behavior, and improve overall school climate. We generally assume that those programs will meet the needs of about 3/4 of the student population, and about 20% of the students will require secondary prevention or what we call Tier 2 programs that are often delivered in small groups and focused on particular areas of need. You'll hear more about that shortly. Finally, a small proportion of students might need higher levels of care, typically offered individually to address specific student needs. Now I'm going to pass this back to Dr. Young for discussion of an example program.
I'm going to talk with you briefly about some of the work we've been doing over the past 15 years developing and studying a school-based depression prevention program. To set the stage for this work, depression is a significant public health issue. Given the high incidence, delays in accessing care, and limited providers who can deliver evidence-based treatment, our current treatments can only reduce about 1/3 of the disease burden associated with depression. For this reason, a number of people have argued that preventive interventions are a possible and necessary way to reduce the disease burden. 2 recent reviews concluded that between 22% and 38% of major depressive episodes could be prevented if existing prevention programs were implemented. Not only would this help address this problem, but these are also a cost-effective way to reduce the morbidity and mortality associated with depression. Research shows that there's a large increase in rates of depression in adolescents, and so for this reason, adolescence is an opportune time for us to think about depression prevention. We've conducted 3 school-based depression prevention studies. For each of these studies, we've focused on youth with elevated depressive symptoms. These are kids who might benefit from indicated prevention or even treatment, kind of in the model that we were talking about, thinking about Tier 2 or Tier 3. As part of these studies, we've conducted depression screenings in middle schools and high schools, focusing on 7th to 10th graders because this is the time of greatest risk. In this work, we have found that our elevated rates of depression vary by school, but that approximately 20 to 40% of youth have elevated symptoms and may benefit from these programs. We know from others' research that these elevated symptoms are associated with an increased risk for depression, and that contrary to beliefs, kids who have elevated depressive symptoms, this isn't necessarily fleeting, it lasts, and they do experience considerable impairment. In these studies, we've also provided crisis evaluations for many youth with especially high scores, and many of these kids were not known to the schools and were not receiving services. Taken together, this really points to the importance of continued screening, prevention, and intervention for depression in schools. The Depression Prevention Program we have developed is Interpersonal Psychotherapy Adolescent Skills Training, or IPT-AST. Sometimes the kids refer to this as Teen Talk. This is a group-based intervention that's based on interpersonal psychotherapy, an evidence-based treatment for adolescent and adult depression. It's really based on the concept that what happens in our relationships impacts our mood, and our mood impacts how we act in relationships. So if we're having a bad day, we're likely to be irritable with the people around us or withdraw. And if something happens in our relationship, such as a conflict with a peer, it's going to impact our mood. The focus of the program is really on improving the teens' current relationships and teaching them communication and interpersonal problem-solving strategies that they can apply both to their current relationships as well as future problems. For instance, we teach kids things like how to communicate their feelings using an I statement, how to put themselves in another person's shoes to show that they understand the person's perspective to try to reduce conflict and reach a resolution. The goals of the program are to reduce their current depressive symptoms and ultimately prevent the occurrence of depression diagnosis, to improve their functioning across multiple domains. And for many of these kids, this is their first time experiencing any type of psychosocial or counseling intervention. And so we want them to have a positive experience so that if and when they need treatment in the future, they're more likely to seek it out because they've had a good experience to begin with. To date, we've conducted 3 IPTST studies in schools. In the first 2 studies, we compared IPTST to usual counseling that consisted of a school counselor or social worker seeing kids for a handful of individual sessions. In our most recent study, we actually asked counselors to run groups that were the same number of sessions as our intervention to get a better understanding of how our intervention may differ and just generally what the impact is of providing these prevention programs in schools. So I'm summarizing about 15 years of research in one slide, and so the results are not always consistent, but generally across these studies, we have found evidence that IPTST is more effective at decreasing their current symptoms. In 2 studies, we found evidence that the program was effective in preventing the onset of depression diagnoses. We've seen evidence that it improves their functioning overall, so that would be with friends, family, and in school. We see that it leads to decreases in parent-child conflict, which is one of the relationships that we typically target in group. And encouragingly, the results are not only for depression, but also extend to anxiety and other internalizing symptoms. We think it's really important to focus not just on symptoms, but functioning and in particular domains that are important to the kids and also to the schools in which we work. And so we have seen evidence that IPTSD leads to improved social functioning and also functioning in the school domain. We are about to embark on another project that we are excited about, which is a continuation of this work, where we will be training school counselors in the School District of Philadelphia to deliver our program and to compare outcomes for adolescents who receive our program versus usual services in schools. We're going to examine a number of outcomes and also really try to understand how we can best support counselors to deliver this program.
Okay, so now I'll pick it up with a couple of more examples from the work that I've done with some of my colleagues in schools in this area. And so we'll start with Project Access, which was a grant-funded initiative funded by NICHD and a clinical trial awarded to my colleague, Dr. Ricardo Araldi, and we just concluded the project. Our goal was to partner with urban schools to support their ability to implement and sustain the use of evidence-based practices for students with or at risk for anxiety or disruptive behavior problems. And this project was developed after a 3-year pilot project that included a needs assessment, and in the course of that needs assessment, anxiety and disruptive behavior problems were identified as primary areas of need for the schools in this area of the city that we were targeting. And in Project Access, this version of the program, our primary goal was to determine whether the school staff could effectively implement the interventions with fidelity, with support from our team. So on this next slide, you see a bit more information about our participating schools. And these schools are located in an area of the city with one of the highest deep poverty rates in the country. So these are families and children that experience very high rates of stress, and the schools oftentimes face very limited resources to meet the high needs of their students. The families also face substantial difficulties accessing care in the community. So the Tier 2 interventions were really seen as a very hopeful. We were very hopeful that this would be a possible way to meet some more of the needs of the students. We were implementing the Coping Power program for disruptive behavior disorders and Friends for Life for anxiety for students in 3rd through 8th grades in these buildings. Our schools were randomized to one of 2 conditions, and basic consultation was comprised of didactic support that was really focused just on intervention implementation. In that condition, we focused mostly on preparation for the delivery of the upcoming sessions. And school partners in that condition did not receive any kind of feedback about their prior sessions. In the enhanced consultation condition, school partners got basic consultation plus very targeted performance feedback about the quality of their implementation of the previous session. So as we've been looking at our findings, we've noticed that content fidelity, or the extent to which the primary components of the interventions were delivered as we intended them, was really very similar across the 2 groups. And then when we looked at this further, though, over time, we found that school staff who initially received enhanced consultation and then were switched to basic consultation over time, we were looking at that over time to see if we reduced our support, could they maintain the high levels of fidelity? And we found that those providers who had that higher level of support but then were back down did in fact maintain their fidelity over time at a higher level than those who just received basic consultation throughout the study. So the bottom line here is really that school staff do need sufficient support to learn and sustain implementation of these types of programs, but that with the right type of consultation, that can be done. And then on our next example, I'm focusing on a newer project that I'm working on with my colleagues, Dr. Tom Power and Dr. Janelle Nisley-Chiappini. We have funding in this project for the Institute of Education Sciences to conduct a cluster randomized trial in 20 schools in this region, and we're actively underway. So we are focusing in this study on the evaluation of an organizational skills training program that was designed for kids who have difficulties in executive functioning, essentially, organization, time management, and planning. And similar to Project Access, in this project, we're supporting school staff in their implementation of the program. The intervention was originally designed for students in 3rd through 5th grade, and it's delivered in 16 small group sessions over 8 to 10 weeks. So again, we're considering this at the Tier 2 level. Sessions are twice per week. The program also includes consultation for parents and for teachers to ensure that the adults that are important in the students' lives can really help with the generalization of the skills that they learn in those targeted student sessions. We're too early in the program right now for me to share anything specific about our outcomes, but we are learning a lot about how the school staff members approach this program. And we've found that the school staff members absolutely can deliver the program with fidelity when we give them sufficient support. And so along these lines, I can get into some important takeaways from today's discussion. So all 3 of our examples today really illustrate that our Tier 2 school-based mental health programs are effective, whether they're delivered by research staff or by school personnel, as long as the school personnel have the adequate support to learn and deliver the program. In all three of our examples, we've learned that buy-in varies widely for these types of programs based on a variety of different factors, unique to the schools and unique to the participating youth and families themselves. So we really have to think carefully as we develop these types of school-based mental health programs to think about what interventions might be of importance to the school communities. We heard about interventions for internalizing difficulties, anxiety and depression, interventions for disruptive behavior problems, and then in the third example, we were talking about executive function, which may feel a little bit more like an academic intervention, though it does absolutely fall within the domain of school mental health. And these programs need to fit with what the communities need. We also need to think carefully about how we design our training and support programs so that they're useful and they fit within the context of the school community. And finally, as we're conducting research, we want to make sure that our outcome measures are targeting domains that are of interest to our partner population.
Great. Thank you both so much for walking us through that presentation. For our listeners, if you would like to access other webinars in the series, please visit policylab.chop.edu. Thank you for joining us.